Thank you. Thank you, Chairman Young and Ranking Member Ruiz. And the members of the subcommittee, I appreciate you having this hearing today and inviting me to testify in support of my bipartisan bill, H.R. 5406. And maybe by the end of this committee hearing, I'll have you on board as well, Representative Ruiz, with all parts of the bill. But this bill is called the Helping Ensure Accountability, Leadership, and Trust in Tribal Healthcare, the HEALTTH Act. And I want to thank today's witnesses who have traveled a long ways to be with us. Mr. Bear Shield and Ms. Church, who are here from my home state of South Dakota. We have Mr. Miller and Mrs. Kitchen, who are here from Nebraska. And thanks also to Ms. Boland and Ms. Smith for being here today and add their perspective. And I don't want to make any mistakes today in telling you clearly we are here because of a crisis. The Indian Health Service is beyond broken. Fixing it is literally a matter of life and death. Nowhere is this truer than in the Great Plains region. The Great Plains service area is home to some of America's most remote and most impoverished tribal communities. Unemployment rates, substance abuse rates, and suicide rates are far above national averages. In fact, many of the unemployment rates in these areas are 80 to 90%. At the center of it all is a healthcare system so deficient that providers are offering care with expired licenses. Their surgical instruments are being washed by hand. Opioids and other drugs are being stolen by the thousands, and premature babies are being born on hospital bathroom floors with no physician present. Last year, CMS terminated its accreditation of the Winnebago Hospital in Nebraska, which serves the Omaha and the Winnebago tribes. CMS then cited the Rosebud, Pine Ridge, and Suisun hospitals in South Dakota. In Rosebud, the situation is by far the worst. Without warning, IHS closed the facility's emergency room, diverted patients to hospitals located over 50 miles away. In the 7 months that the ER has been closed, 5 babies have been born in ambulances, and 9 people have died in transit to these other hospitals. So literally, we're talking life and death. I want everybody just to think of this perspective too, because I think it's important to know that IHS is a subset under HHS, as is CMS. So CMS actually refused to reimburse the kind of care that was being delivered at IHS facilities, both under the same umbrella of HHS, which tells you, and we have one federal agency pointing out how terrible of a job one other federal agency is doing, that literally every single day it's important that we recognize how terrible the situation is. In the years since the 2010 Senate Indian Affairs Committee report that outlined many of the most shocking problems, the IHS has promised again and again to make changes, but it has failed to do so. Even at the most basic levels, if you thumb through the past IHS budget requests, you'll find the same promises copied and pasted from one year to the next. This is the very definition of status quo. What has changed is the funding. Congress has delivered funding increases to IHS almost every year since the Senate report, bringing the annual IHS budget almost $1 billion over 2010 levels. And yet the situation is just as bad as it's ever been. So we know for a fact that money alone is not going to fix the problem. The HEALTH Act reforms an agency that's in desperately need of an overhaul. Many tribes are considering self-governance, which you indicated, Mr. Chairman, works well in Alaska, but for a number of reasons, many of my tribes aren't quite ready to administer a hospital. When they're so impoverished and lack so many resources, they want to eventually end up there, though. That is the goal. So my bill creates a pilot project in which hospitals can be controlled by tribal-led boards rather than IHS. This new model will give tribes more control over their hospitals and equip them with the expertise that they need for self-governance. The IHS's chief obstacle in the Great Plains is staffing. To improve recruitment and retention, my bill extends the agency's student loan repayment program to administrators as well as medical staff and makes this financial support tax-free, like other government programs that are already out there designed to attract providers to underserved areas. This will make the repayment program a more valuable tool to recruit more competent administrative and medical staff. We also require cultural competency training to ensure that IHS employees understand the people that they're serving. We ask the agency to report their wait times, and we eliminate barriers that currently prevent medical and dental providers from being able to volunteer at IHS facilities. And finally, the HEALTH Act reforms the Purchased Referred Care Program, which currently operates under an unfair funding allocation formula. My bill would require that IHS update this formula and ensure that the money is getting to those people who need it the most. As I've said before, I believe IHS should get out of the hospital business. I think they're terrible at it. And my bill takes us in a step in that direction under this pilot program. We have received widespread support, including from the Rosebud Sioux Tribe, the National Indian Health Board, all the major health systems in South Dakota, national and state health organizations, but we're not done. I look forward to a robust discussion today, and I welcome all of the input from the subcommittee, the witnesses, and the tribes across the country. Chairman Young, Ranking Member Ruiz, and the members of the committee, thank you for allowing me to testify today, and I truly thank you for your commitment to improving tribal health care. And with that, I'll yield back.
Thank you.